So the last talk of the session, we have Dr. Akruti Desai, and she will be presenting a case of orbital trauma, globe interception, and she has been an ex-fellow of L.V. Prasad Eye Institute and presently working at Shantilal Sanghvi Eye Institute. Over to you, Dr. Akruti.
Good afternoon, everybody. It's a pleasure to be here back in Calcutta after 8 years. So my case is of orbital trauma of globe interception. I'll come to why it was called that way. So there was this 17-year-old girl who presented with a bullhorn injury, of a day-old injury, trauma with a bull's horn 1 day prior, came to the clinic in the evening. Her visual acuity in the right eye was 20/20. She said there was sudden painful loss of vision. She didn't know what exactly had happened. There was no perception of light in the left eye. There was no globe visible. Severe conjunctival chemosis, hemorrhage, and a small eyelid laceration on the upper eyelid. So as you can see, when we open up the eyelids, just a socket was seen with conjunctival chemosis and subconjunctival hemorrhage. So the resident who was present suspected either it is traumatic enucleation or an ophthalmic socket. On imaging, it was seen that there was globe seen in the left maxillary sinus. The trauma must have been severe enough to cause such severe globe dislocation in the maxillary sinus. There was a large floor fracture with loss of inferomedial stud, like Dr. Ganga and Dr. Grover have beautifully presented orbital fractures. So without the loss of the inferomedial strut, it's not possible for the globe to completely dislocate into the maxillary sinus. Intraoperative, this is an intraoperative picture where deep into the socket, the cornea is barely visible. The surgical technique that we followed, there are multiple, either transconjunctival, subciliary, and Calderon-Duck. All three techniques have been described in literature. And since it's not very common, there are limited cases which have been reported. So the technique that we followed was a Calderon-Duck procedure, wherein an opening was made just lateral to the pyriform fossa, up to the lateral end of the maxillary sinus, and just below the inferior, the upper edge was just below the infraorbital canal. Care has to be taken that the inferior edge has to be above the root of the canine tooth. The anterior wall is gently removed, and the globe is gently pushed so that it is at least visible through the orbital socket. A transconjunctival peritomy 360 degrees was done. Fortunately, all muscles were intact and they were hooked to ensure that the globe can be retrieved easily. Floor implant, a rigid floor implant of titanium 3D was implanted just below the periosteum, and the oral cavity wound was closed. This was her immediate post-operative picture where there is still some subconjunctival hemorrhage, but you can see the globe in the orbital socket. And 2 months later, it looked much better, but her visual acuity remained no perception of light because there was probably a 2-day delay and there was severe trauma causing dislocation of the globe in the sinus. This is a fundus photograph. In the immediate post-operative period, there were retinal hemorrhages and there was generalized retinal whitening. And 2 months post-operative, there was complete optic disc pallor with sclerosis of vessels and pigmentary changes at the macula. So coming to the discussion, there is just not the loss of floor, because there have been cases where there is loss of the maxilla along with the floor, but it does not cause complete dislocation of the orbit. So definitely when there's a forceful trauma, there is a disruption of the ligaments, the bulbar fascia, the orbital fat prolapse, and the globe can telescope it through the conjunctiva into the maxillary sinus. Why is it called interception is, as we are aware, in acute obstruction of the intestine, there is telescoping of the intestines causing blockage of the distal end of the intestines. Whereas here, with the forceful trauma, the globe is telescoping through the conjunctiva into the maxillary sinus. So if you consider the anterior edge of the telescope to be the bony wall, the one beneath as the conjunctiva, then the tenons, and then the globe. So that kind of helps us understand the mechanism by which the globe might be telescoping into the maxilla. A review of literature was performed, I did from 1971 to 2020, looking for terms like traumatic globe dislocation and maxillary sinus, and we found that there were 24 cases, similar such cases reported. Although maxillary sinus is more common, it has also been reported into the ethmoid sinus as well. More than 50% of these cases are due to road traffic accidents. There was just one case previously reported which was due to a bullhorn injury. In the outcomes, about 33%, 33.33, recovered some amount of functional vision, and 5 of them were reposited on the same day, whereas the other 4, the time duration from the trauma to the reposition has not been reported. Not been mentioned in the papers. So to summarize, interception of the globe can be misdiagnosed as anophthalmic socket or auto-evisceration. There are 2 techniques, either direct traction by subconjunctival or subciliary approach, or transmaxillary approach. Reconstruction of the flow needs to be done by a suitable rigid implant to prevent a late dislocation again into the maxilla. And irreversible vision loss, as coroner has mentioned, is due to either direct trauma to the optic nerve or twisting and stretching of the central retinal artery when the trauma has occurred. The choice of approach, we feel, should be guided by the proportion of dislocation as demonstrated in the CT scan. If it is more superficial, just a transconjunctival approach would be possible, subciliary approach could be, transconjunctival approach, either with a peritomy or a direct transconjunctival approach would be possible to retrieve the globe. But if it is deep into the maxilla, then a supportive Cadwell duct might be beneficial in retrieving the globe. So we would recommend 360-degree peritomy with suture tagging of extraocular muscles, which can ensure safe repositioning into the orbit with intact extraocular muscles, because when you're going blindly into a balloon conjunctiva, you may traumatize the globe as well while trying to tag the muscles. Thank you very much.
Thank you, Dr. Akruti, for that wonderful